Okay, so it's 2 minutes past 6 Paris time, so we will be starting. Hello, everyone. Welcome to this webinar, which is organized by Olea Medical. The topic of the day is clinical implementation of multiparametric MRI. Before I go further, I want to review the functionality of the Cisco WebEx functionalities. Your active participation is important during the session. Run to avoid background noises. Throughout the presentation, I will be managing the chat functionalities and your questions in the chat section. They will be answered during the question and answers part. Now, I'm very pleased to welcome you all and introduce you Professor Dr. Katja Pinker. Dr. Pinker-Domenig is a member at Memorial Sloan Kettering Center, attending radiologist at Memorial Hospital for Cancer Allied Diseases, and professor of radiology, Vail Medical College of Cornell University in New York. She is the head of the Translational Imaging Research and head of breast MRI at the Department of Radiology Breast Service at the Memorial Sloan Kettering Cancer Center. She's affiliated faculty at the Department of Scientific Computing at Florida State University, Tallahassee, and she's an expert in translational and clinical breast and oncology gender imaging. Her research interests focus on molecular breast imaging, advanced high-field, ultra-high-field magnetic resonance imaging, using multiple advanced MRI parameters and hybrid techniques, such as position emission tomography, PET MRI with specific traces, and the application of AI in oncologic imaging to develop imaging biomarkers for precision medicine. She has published more than 80 peer-reviewed papers in breast and oncologic imaging. And as I mentioned at the beginning, she will be talking about clinical implementation of multiparametric MRI, which is a topic dear to my heart. So enjoy the webinar, and I will answer your questions at the end. Professor and Dr. Pinker, whenever you're ready, the floor is yours.
Thank you very much for the kind introduction. Yeah, this is also a topic that is very dear to my heart. So I'll be talking about the clinical implementation of multiparametric MRI. And what is the rationale for that? Well, you know, MRI of the breast is the most sensitive test for breast cancer detection. We know that. And DCE MRI is the backbone of any given MRI protocol. It provides 3D morphologic and also functional information on tumor neovascularity. And one thing I really always want to reiterate in every presentation, it has a good specificity. It's sort of a myth that it has a low specificity depending on study that ranges from 80 to 97%, which is as good as and higher as that of mammography. One thing that it separates it also from other imaging modalities we have is that it is independent of breast density and can visualize invasive as well as non-invasive disease. So like we can also like see based on neovascularity, small cancers like in this example here. However, as I've said, it has the highest sensitivity and a good specificity. The specificity is not as good as it is the sensitivity. So that means we're still having false positive findings because of the high sensitivity with a PPV of approximately 35%. And we're performing unnecessary biopsies in benign breast tumors. And this is like an imaging example where you can see an irregular shaped enhancing mass. You will have to biopsy that because that is from a morphologic point of view and a kinetic point of view suspicious. If that comes back as something high risk or benign, well, then you will believe it, but still there's no way of actually saying what is it. There have been, of course, improvements to DCE MRI. When you think about where we started out with lower field strengths, then moving to 1.5 and 3T, and we also have increased the resolution. So when you think about it, like we have or everybody, I think, is doing fast protocols in the sense that our temporal resolution from the time points after contrast are 60 to 90 seconds with an in-plane resolution of 1 millimeter. But there are ways of actually increasing resolution and going to faster and ultra-fast protocols where you have simultaneous high spatial and temporal resolution. So, for instance, the faster protocol would be like scanning every 10 to 15 seconds with the 1 millimeter in-plane resolution or even below that. And ultra-fast protocols usually combine in the first pass, in the first 60 seconds, ultra-fast resolution, temporal resolution, like 3 to 4 seconds with a lower spatial resolution, followed at expected peak enhancement when the first pass is over, a high spatial resolution. So there are ways of improving DC MRI, and this is actually already helpful. Yeah. So in this case, this is one of our protocols where we scan in the first 1.5 minutes with a faster resolution, and you see the cancers already start enhancing after the second time point, whereas the BPE comes later. So these are ways where you can, by faster scanning, you can improve already your sensitivity and specificity. So this was a patient where we had like a baseline scan, and she had on both sides, she had those areas which were in prior scans sort of hidden in her BPE, but they enhanced very early, and that prompted us to do biopsy, which was on the right side a high-grade DCIS, and on the left side at least a high-risk lesion. We can also go to higher resolution in the sense of a spatial resolution thing, moving to higher field strength. And there is something to be said for that. I mean, this is a patient where we have actually the direct comparison from 3T to 7T. On 7T, we see a clumped linear non-mass enhancement, which I personally wouldn't have called on the 3T scan. And based on that biopsy, that was a high-grade DCIS. But however, do I advocate to go to 7 Tesla everywhere? No, because it's not widely available. And there are other ways of improving yourself. So this was a patient who underwent a 7 Tesla scan in a study setting, and we saw this irregular enhancing mass that came back as a benign fibroadenous hyperplasia. But again, with DCE, at one point you reach the glass ceiling. So it is like there's only so much more you can add by going faster or by doing higher resolution. So, and that I think is a unique opportunity for us imagers to provide more. When you think about the hallmarks of cancer that had been identified, there are several processes that cancers do in their development, which is not only neoangiogenesis, which we visualize with DC MRI. There are other capacities that cancers do, which we can capture with imaging. And this sort of sparked the concept of multiparametric and even multimodality imaging. And this would be, I think, that this is the main 4 things we can sort of do in clinical routine beyond the study setting. So there is diffusion weighted imaging. Of course, we also have PET in case you have a PET MRI scanner. There's also valid metabolic information there, or spectroscopy. But in this presentation, I actually want to focus on what is actually done in the clinic and what are the recommendations to do in real clinical life. So multiparametric MRI in clinical practice, theoretically, you can combine 2 or 3 parameters. DC MRI and DWI is the most common. Theoretically, you could also do DC MRI and spectroscopy, or you combine, if you have the time and the energy, you can do also 3 parameters. So I first want to focus on multiparametric MRI with DC MRI and DWI, because I think that is the most important and most researched and valuable combination. When we think about diffusion-weighted imaging, so diffusion-weighted imaging visualizes cancer through hindered diffusivity, which we can quantify through the apparent diffusion coefficient. So in benign tissue, the cells are loosely grouped and the water can move freely within the cells. Whereas in malignant cells, which have different shapes and sizes and are sort of bloated, and the water cannot freely move within them. And this we can capture with imaging. We capture this hindered diffusivity and quantify that with the apparent diffusion coefficient. So just to give you an idea, this would be like for the benign lesion, that is a fibroadenoma, where you can actually say on the high B value, it is actually slightly standing out. Yeah, this is because it is on T2 weighted imaging, very bright. This is the T2 shine through. That's why you need the ADC value to quantify it, because when we look at the ADC map, this is like completely bright. This is not a cancer. Whereas the cancers, they show up with restricted diffusivity. They are bright on the high B value image and then show a decreased signal on the ADC map. So they are dark. The DWI with ADC mapping is a fast technique without using any contrast agent application. So like you, depending on what scanner you have, it will be something between 3 and 5 minutes. And it demonstrates malignancies based on the refused water diffusivity relative to the normal tissue. So it helps definitely to distinguish the benign and malignant lesion, can identify mammographically occult lesions, and there's also now a push moving forward into non-contrast screening, which is actively researched by several sites by now. And again, in the lower row, you see the B0, that is basically a T2 weighted image, so you get T2 weighted information as well. Then B0, where the cancer sure stands out with the restricted diffusivity and the quantification with the ADC map. I'm actually very pleased that I find that we have out this paper from the International Breast Diffusion Weighted Imaging Working Group from the European Society of Breast Imaging, which considers DWI an essential part of a multiparametric breast MR protocol. And just to give a little background on the paper, this International Breast Diffusion Weighted Group, that is was a consensus meeting and mission statement from diffusion weighted imaging experts, breast imagers, vendors all over the world. So the authors that are here are the steering committee, but actually there's like the whole group is a large group experts from diffusion weighted imaging all over the world who have designed these recommendations. In this paper, they're laid out the minimum requirements for DWI of the breast. And I'm not going to go through everything. You can search the paper online. It's open access. But you should have a high B value of at least 800 milliseconds. Optimal, you can go higher if you want to. You can also do synthetic B values, but you should have at least 0 and 800, or at least as practically as close as possible to 0, but not exceeding 5 for the low B value. In-plane resolution should be 2 by 2. The type of sequence is usually EBBI based, and the generation of IDC maps is required. So this really is something important for breast imaging. Given that there are many studies out there, which all the studies have slightly different thresholds, but very much the same. So while in my study, I found that the optimal cutoff for malignancy is 1.25. Other studies have 1.3, other studies have 1.28. So to mitigate that and provide guidance in reporting, we came up with diffusion levels. So basically in between 1.4 and 1.3 and 1.7 is intermediate, that is, and everything above is high and very high. This is considered benign. Everything below 1.3 is considered low and very low. So we are giving it a qualitative aspect than an actual number, but this is considered suspicious. And so how should you use that in clinical practice? So basically what you're gonna do is, and this is how I implement it in clinical practice. I first look at my backbone. I look at the DCE scan for an enhancing suspicious mass. And then of course you have also your T2 weighted sequence where you can look at non-enhancing masses and probably see whether it is a proteinaceous cyst or not. But DCE is the backbone to finding malignancies. If you see an enhancing lesion, then I go to the DWI, to the high B value image, and see if I have a correlate with the restricted diffusivity on the high B value image. And then I go there and measure the ADC value. And I think this is a crucial thing. I measure to give me my value and can classify, is this a low or very low, or is there a level of diffusion restriction? In this case, we have a lobulated enhancing mass where we can discuss whether there is a hypoechoic septum or not, a hypointense septum or not. And on the ADC map, the ADC is 1.4. We always look at the mean value and we draw the ROI in the most suspicious part of the lesion. So where by visual assessment, the ADC is the lowest. This is indicative of a benign lesion, and that actually was also a benign lesion. So all the cases I'm showing here, we biopsied because it was in a study setting. But the idea is with multiparametric MRI that you can avoid unnecessary biopsies. And then here is another example where you have already a lesion, which from a morphology point of view, obviously is already suspicious. We have an irregular shaped mass with probably associated non-mass enhancement. On the high B value, we actually see the restricted diffusivity, and I think it actually also mirrors nicely that you can also get sort of morphologic DWI information out of that, because it mirrors the appearance on DCMRI. And then when we measure our ADC, again, we draw a single ROI in the most suspicious part of the lesions. The ADC here is 1.064. That is definitely below the cutoff. That is a very, actually, I think it already qualifies as very low diffusivity. So this is classified as malignant, and that was obviously a cancer. And I mean, There are limitations to diffusion-weighted imaging in the sense that sometimes we have trouble just seeing our lesion. In this case, we were lucky because that 0.4 millimeter cancer that showed up on a high-risk screening patient. And I mean, when you look at the lesion, consider you wouldn't have a prior and you wouldn't know that this is new. There is an oval circumscribed mass in a young patient. Well, probably you would send that into follow-up and not necessarily immediately biopsy that. Well, in this case, it showed up with the restricted diffusivity, and when we measured the ADC, it was 1,000 to 1.03. That is definitely suspicious, and we biopsied, and that was basically a cancer in this high-risk patient. So, I mean, in that case, this what pushed me more towards biopsy. In other cases, the DWI will confirm that my gut feeling that this probably should be a follow-up. And these are, so again, to reiterate the diffusion levels. If you want, of course, in your report, you can give it an absolute value, but you can also, it's also perfectly okay to actually go by the diffusion level to describe your finding. So in the paper, there are also a lot of examples provided which show you how different entities will be looking on a diffusion-weighted imaging, and I can highly only encourage to read the paper. It was a gargantuan effort to put this together, and I think the International Diffusion-Weighted Imaging Group is really proud of that paper. And when we go, like, apart from the consensus statement, when we look at what is out in the literature, is that like sort of a bunch of experts who think that diffusion rocks? No, there's actually also meta-analysis, systemic reviews who looked at that, and this is what we try to instill in this consensus statement. So for this consensus statement, we reviewed all the literature, all the reviews, meta-analyses that are out there, and there is an overwhelming consensus that diffusion-weighted imaging improves specificity. So when you look at this meta-analysis, the overall sensitivity and specificity of DWI is 90 and 86. Then there's often a question, why don't you do just DWI alone if the sensitivity is that great? Well, you have to consider that for all those studies, it was never reviewed as a standalone modality. You had the backbone of the DCE MRI, which showed you, and then it was like the lesion that I'm seeing on DCE, can I also see it on DWI? This is where the sensitivity comes from. What is an overwhelming consensus is that it is more specific than DCE MRI alone, and there you can do it at both at 1.5 and 3 Tesla with good imaging quality. So that meta-analysis actually reviewed specifically the question of multiparametric MRI with DCE MRI, DWI MRI alone, and exactly came to the same conclusion. DWI is sensitive. The one thing is that you miss out on very small lesions or diffuse lesions. DCE MRI is definitely the rock star when it comes to sensitivity and specificity. It is superior to DCE MRI, which the maximum accuracy, so the maximum AUC and diagnostic accuracy. So if you should do anything, you should do both, and you should put the information of both imaging modalities together. And I think it stands to reason. More information is better than one, but if you have one piece of the puzzle or two, what will make it easier for you to see the full image? And that is has been confirmed by numerous studies that are out there. We at one point, we also wanted to investigate if we can actually base the levels that we should be using for masses and non-masses on our workhorse, the Biarritz Atlas. And in this study, we looked at that and we basically defined different thresholds. The consensus statement also thought about this idea, but we wanted to provide a less complicated, so that's why we came up with the qualitative diffusion levels. However, we found with the Biarritz adapted reading, we actually found the same thing. We can maintain the sensitivity, maximize diagnostic accuracy, and it's also fast and easy to use. But for clinical implementation, we have now a consensus statement. I would rather recommend to do the levels. So in general, this was a patient who had a small, tiny, partially irregular mass. And the thing is, in that case, she had an ipsilateral cancer somewhere else in the breast. This is sort of a dilemma. This was in a different quadrant. The patient had a cancer but wanted to go for breast conservation. So in this case, we biopsied based on that. But from a diffusion point of view, we wouldn't have necessarily if we had encountered that in a single lesion setting. And this diffusion-weighted imaging said that this is a benign lesion. That actually was it. So the idea is that with multiparametric MRI, with DCE MRI and DWI, we should be avoiding unnecessary breast biopsies. This is another example where we actually already initially, we didn't even recommend biopsy in all fairness. We said this is most likely a fibroadenoma. We have the morphology, the non-enhancing septum, the diffusion is pointing in benign. The patient actually insisted and she didn't even want biopsy. She went straight for surgery. So that's why I really know that this is a fibroadenoma. And in this case here, again, you can also see that it's the diffusion-weighted imaging is nicely also mirroring what we see from a morphology point of view. You see the extensive intraductal component creeping forward with the non-mass enhancement. So it is a very robust and easy to use method. So, and this is one of the cases where I was like, that was my first thing where I was super impressed with diffusion-weighted imaging. That was a patient who presented for normal screening, young age. Yeah, that was one of her baseline scans when she actually was below 40. We found a benign mass and we asked her, like, would you participate in, we thought a benign mass. We asked her to participate in our multiparametric imaging study at that time. She was so kind to agree. And when we saw that lesion, I mean, it is continuously enhancing. But on diffusion-weighted imaging, this is a dark hole, and that was quite concerning for us. We actually biopsied that based on that finding, and that turned out to be a breast cancer. So this is one of the things where I was like deeply impressed and further confirmed that I should be using DWI. Also, when you look at it from a model perspective, we also modeled to see what virus descriptors and what other sequences are necessary for the most optimal diagnosis. And also on the model development, we saw that when we incorporate the DWI with ADC mapping in our model, that gives you the best diagnostic accuracy. So we have the ADC, we have the mass margins, we have the delayed enhancement, which were significant independent predictors for differentiating benign and malignant. That sort of very nicely mirrors what the literature says, but I'll have it confirmed on a model basis. That also was a feel-good factor. What about spectroscopy? Spectroscopy has been around and is a very intriguing technique because you also get metabolic information. The one limitation of spectroscopy, I think that has hindered that this widespread use, that first of all, you have to pick which breast you're doing. You can only do one breast at a time. So it's not one-stop shopping where you have image visualization of both breasts in a short time. It takes time. If you want to do whole breast coverage, it actually takes up to 10 to 30 minutes, depending on breast size. If you do single voxel spectroscopy, you will have to know where the lesion is and can only focus on your lesion. Well, there is relevant information. We can find colon compounds which are indicative of malignancy, but despite adding specificity, I think the more value is in the therapy monitoring setting. There's a meta-analysis which looked at spectroscopy and found that it is a reasonably sensitive test and has, again, very good specificity. So the value would be adding additional specificity. The thing is, preferentially, you should do it at 3 Tesla because you can get it's more information out of that. It works better. The one thing is that is, again, the poster child patient with the choline peak. The thing is, it adds specificity. There is no question about that. It increases diagnostic accuracy, but it also adds time. In addition, it's also from a acquisition point of view a little bit more challenging for the technologists. So if you have to do something despite the increase of diagnostic accuracy, there's actually a paper who looked at that. What you should do, whether clinical breast MRI should be doing DWI and or spectroscopy in a multiparametric setting, there's a broad consensus that for the time being, until there are significant improvements from a time acquisition point of view, from breast coverage point of view, you should stick with DWI. If you can do both in your clinical practice or you want to do it in a study setting, we do encourage spectroscopy, but from a clinical day-to-day use, we would recommend diffusion-weighted imaging. Diffusion-weighted imaging is great, and there is a push, as I've said, going towards non-contrast enhanced MRI. We looked at that formally because, I mean, this is an intriguing question. Can we ditch the contrast and offer our patient the same quality? The thing is, it depends on what is your benchmark. If your benchmark is having the sensitivity and specificity of mammography, you're already there with non-contrast screening. The thing is, if your benchmark is dynamic contrast enhanced MRI, then you have still a little bit of work to be done, which mainly I think is, and actually there's active work towards that. The main limitation is currently the resolution we can achieve with diffusion-weighted imaging. DCMRI, and this is a study where 4 readers from all across the world read a set of cases to find out what, and they read the diffusion-weighted imaging completely alone without any supportive sequence. And I think that would be the aim of doing non-contrast screening, not do a bunch of sequences, just not give contrast. The idea would be a 3-minute non-contrast scan patient out, yeah, so in a screening setting. So and this shows that DCMRI is still the most sensitive test. It is less specific than DWI, but DWI alone misses some cancers, in particular small and very diffuse lesions. And currently, if your benchmark is DCMRI, you cannot use it as a standalone parameter. Multiparametric MRI, best of both worlds, that maximizes the diagnostic accuracy without compromising on sensitivity. However, I think the future is bright for diffusion-weighted imaging. There are already a lot of improvements from a sequence technology. We have readout segmented EBBIs, multi-shot, multiplex sensitivity encoding. I love the name Muse, by the way. And so that already gives you better quality images, less artifacts, higher resolution, and there's a great potential for non-contrast screening in there. And there are several groups across the world who actively are working on further increasing the resolution of diffusion-weighted imaging to make it ready for prime time in screening. Higher p-values are also, I think, will be also relevant, in particular in a screening setting, because higher p-values have the lesions stand out more. It provides better conspicuity lesion visibility than at lower high p-value. And currently the studies are recommending across the board some p-values between 1,200, 1,500. One drawback of higher p-values is actually it extends scan time. So you will have to invest more scan time in your diffusion-weighted imaging scan. Question is, do you want that, or do you feel it is sufficient to do the B800? And solution out is synthetic higher p-values, where the higher p-values are synthesized. It doesn't increase scan time, and so it avoids performing DWI at very high p-values. It synthesizes the values, though your ADC will come from your high p-value of, in that case, usually B800. After having raved about how great diffusion is, I want to put out some caveats. Yeah, that is the reason we should always use it in conjunction with all the sequence we have done. In reality, I look at DCMRI when this is a completely negative scan. I'm not necessarily moving further to any sequences. If there's something enhancing, I will look at my diffusion-weighted imaging. If there is a rim enhancing lesion where I think it's an inflamed cyst, I will also go to my T2-weighted imaging, because although D0 is a T2-weighted image, the resolution of the proper T2-weighted scan is higher. So I really encourage you to look at all the sequences you have when there is something to see. If there's nothing to see on the scan, you can probably just check if there was contrast actually administered. If there's the dark heart sign, the heart is dark, no contrast was administered, then you have to rethink. But other than that, if it's a completely negative DCE MRI scan, you can move forward. Pitfalls would be this lesion here. So this is, and actually I think this is a very nice imaging example where you can see that the patient actually also with implants, you can do decent diffusion-weighted imaging. She has, like we all agree, I think a segmental clump non-mass enhancement, and this is the diffusion-weighted scan. This is suspicious from a DCE point of view. There's no discussion about that. Linear clump segmental, I have said like 3 bad words in one sentence. And the diffusion-weighted imaging was done. We can discuss, is there like a little bit of restriction? But when you measure it, the ADC values are above the cutoff of malignancy. That was her mammogram. There was not much to see. We also had implant displaced views, nothing to see. We found an ultrasound like this hypoechoic areas where we thought this is suspicious. We biopsied, and that came actually back benign. We all said this is discordant. Now, since we have tried with ultrasound, we're gonna move forward to MRI. The biopsy, the patient declined. The patient deferred biopsy and rather wanted to go into follow-up. She didn't come for the recommended follow-up after half a year. She showed up after a year. We actually see our clip is not even that bad. Our clip was actually in that area. And when we do magnification views, I mean, it doesn't really stand out that much, but what you could see on the magnification views, that there were tons of calcifications now in that area. And I mean, of course we have to biopsy, but for reasons out of interest, we actually all wanted to have an MRI. And now you see we have here now extensive segmental non-mass enhancement. We can discuss if there's already clustered ring components to it, which are usually indicative of kind of a DCIS with from a higher grade. Of course, we did a biopsy. And now you can see now that the lesion have reached a critical mass, we see the diffusion restriction, we have decreased ADC values, now they are malignant. So in that sense, you should be aware of the pitfalls that multiparametric MRI can have and use your gut feeling. In this case, again, we biopsied under ultrasound guidance because it was now so evident, and it was a high-grade DCIS with multiple little foci of microinvasion. And this is one of the things where here also when the lesion is too small, this is a 5 millimeter enhancing invasive ductal carcinoma. Honestly, on a standalone DWI scan, I certainly wouldn't have called that. And also, this is like where the measurement of the ADC is in the middle of nowhere. So be aware, if the lesions are too small, you might miss them. Other pitfalls are, and these are usually not a diagnostic dilemma, this is clearly a morphologically suspicious enhancing cancer. Why are the ADC values so high? What could be the option? I mean, like it's on T2 weighted imaging, it was a very bright cancer. Like this is like also on the B0 image, it was really bright. In this case, that was a mucinous carcinoma. We expect mucinous carcinomas, which are bright on T2 imaging, to do that because the cancer cells float in the mucin, which gives you the high signal and therefore sort of dilutes your ADC. So this is another pitfall you should be aware of. And there are pitfalls that you simply cannot avoid. Patient actually clinically asymptomatic, shows up for screening. We see this asymmetric, this asymmetry. It's like we say rather global asymmetry, which was actually new compared to another screening exam. She was so kind to participate in our multiparametric imaging study at that point, and we were like, okay, this is a cancer. This is like irregular enhancing, non-mass enhancement, almost segmental distribution. The ADC, see there are areas which are totally restricting. We have to biopsy. This is a cancer. That actually turned out to be, and we at first we said discordant. She had another biopsy. This was a chronic granulomatous mastitis on dual biopsies, abscess, no malignancy. On the second biopsy, we actually did a culture, and it was like interesting, like a sort of a like not very common germ for our region. And she responded well. I mean, originally there was the discussion, should they take that out? But the patient deferred that, and she's doing actually fine. So there's still room for improvement, I think, there in the future, but I'm not going to talk about this. This is like beyond the scope of this presentation. For DWI, there's more to come. We're working actively on diffusion tensure imaging, cortosis imaging, IVIM. So there's a lot of other more advanced DWI modeling that can further improve our specificity and add. But this is really currently in the research realm, and the focus is clinical implementation. So when I summarize now, clinical multiparametric MRI to date comprises DCMRI and DWI. Based on your clinical indication, you can also perform it with 2 or 3 parameters, adding, for instance, spectroscopy if it is in a treatment response assessed setting. There is no discussion that multiparametric MRI with DWI and DCMRI improves diagnostic accuracy in breast cancer diagnosis. It obviates unnecessary biopsies, and I think has also more potential for biomarker imaging. So here we have a patient who has a mass, and the story is the patient had like a personal history of a vaginal sarcoma. It's like but remote, like years back. She shows up with this lesion, which we of course all said this is suspicious. This needs a biopsy. The patient was very convinced that as it showed up overnight, it must be a cyst, and we had a long discussion whether we should actually biopsy that. And she was trying to convince me that this, because there are some hypoechoic errors, this must be a cyst. So I sort of negotiated with her what else we can do to find out that whether this is not a cyst. And I recommended, and I said, let's do an MRI and just go back to look at the size of the mass here. The MRI was performed, I think, 5 days later, and we see a scary lesion. That is like a rapidly enhancing lesion, which with the naked eye shows like really a washout in several areas. We have perifocal edema on the T2 weighted imaging. We have restricted diffusivity. We have ADC values, and this is like what I want to draw your attention to, 0.4. So, and when she came back for the biopsy, this was like 9 days later, 9 days. I actually had to use the abdomen probe to get the lesion in the full field of view. And you can see here, this is post-biopsy, and it's not the hematoma. The lesion actually really increased that size within 9 days. And what was that? Well, and this is, I think, where like ADC also already points us in the direction of biomarker imaging. This breast was actually a sarcoma. Yeah, and that we could have already gathered that from the ADC values, because the cancers usually, even the most aggressive cancers, usually do not go below 700, 800. Yeah, so whereas different malignancies, not breast origin, like sarcomas, lymphomas, can go very much below. So you could actually already can press your pathologist and tell them, this is suspicious and for malignancy, but probably not breast origin. So I think with diffusion-weighted imaging, DC MRI, multiparametric eye, we are able to identify the good, the bad, and the ugly, and that way we can identify what needs biopsy. And in this case, we could have already said, like, this is also a bad one, but it's probably a different kind of bad. With this, I want to conclude, and I hope I've convinced everybody that multiparametric MRI is the thing to do in clinical breast imaging, and I'm pretty sure there is more to come from both diffusion-weighted imaging, improvements in other sequences and other parameters. I'm happy to answer any questions now. Thank you.
Thank you. Thank you very much. What can I say? That was a brilliant presentation. Absolutely brilliant. That's great. Thank you very much. I'm really impressed. And I can tell you that I'm not the only one, because I have a bucket of questions. So if you agree, then I will start asking you a couple of questions, and in the time that we have. So the first question I have is, have you found an important relationship related to timing of the DWI acquisition with respect to the gadolinium injection?
Yeah, so I mean, in general, it is recommended to do it before injection of gadolinium. The thing is, however, some institutions perform it after, and there have been studies, they show that it slightly changes the ADC values, but not in a diagnostic significant setting, in the sense, if anything, it makes them slightly lower than higher. So it's not that you will overlook a cancer because you did it post contrast. I mean, in reality, also it really depend. For instance, currently, we're doing it after contrast on one scanner, because like we have to, we use currently the Muse, the multiplexed multi-shot DWI. For this, I have to switch the scanner. Although it is a product, I have on the Premier system, I have to do it in acquired in research mode. That limits me, so I have to do it after. So whatever works in your institution, there also have been, I think, kind of interesting concepts that they said probably I can do a DC MRI first pass imaging in the sense of an abbreviated protocol, do my first minute, then I do a DWI, and then I do one sequence delayed. I mean, currently that is not within ACR accreditation, but it's, I think, an intriguing idea. Yes, there is an impact, but it's not diagnostically relevant. If you go by the books, I would recommend to do it before contrast agent application. That's clear. Yeah. Okay, then the next question would be, we've heard about texture analysis, and what would be the role of texture analysis in breast lesion characterization? Is it, in your opinion, is it something useful, or is the multiparametric DWI-DCE is already powerful enough? So, I mean, I have a heavy focus on AI applications and radiomics analysis. So this is the new fancy word for texture analysis. Radiomics analysis is coupled with machine will have, I think, a role in the future. The problem at the moment, we are looking into that, and we have seen that in particular, it can add in very small lesions, this high risk benign appearing lesions where you want to single out, do I have to biopsy that high risk mutation carrier, yes or no? The results are encouraging. The problem to date is, and that is why this is currently not used in clinical practice, we don't have a plug-and-play solution. If you will have a platform where you just like click your lesion like you do, now we have this, for instance, like the Olea platform or other platforms have it that you see your enhancing scan, you go on your column map, you click the lesion and it analyzes the functional tumor volume, gives you this is washout, this is plateau. If you have a solution for radiomics analysis for that, a commercially available plug and play solution for the clinics, I think then we will be using it. This is, I think, further down the line, and it will further improve us. Yeah. But at the moment, the reason why this is not in clinical practice, because there is no available solution. There are a lot of encouraging results. There's a lot of drive going into AI, but a commercially available solution, which we can do plug and play in the clinics, is not there yet. I think it is down the line, and I have a heavy interest in that. I have seen that there are questions where it will add, because we have multiparametric MRI, but we're still looking at it with our radiologist's eye. There, we know that our human perception, there are things I cannot see, I cannot decipher based on my qualitative assessment alone. So other adding quantitative assessment in aid by the machine will, I think, provide further information. And down the line, I think it will be there. The reason why it has no standing at the moment is because there is no solution that is applicable in clinical routine.
Thank you. Thank you for these comments. You can be sure that the people at Olea are taking notes like crazy right now. So next question would be, would you be kind enough to comment on 2 points? The first one being DCE abbreviated protocol versus standard protocol, and the second point being simple kinetics washout versus permeability, Ktrans and EBBI, for example.
Yeah. So abbreviated MRIs, I mean, I think it's a very important topic and point, in the sense that we now have the abbreviated, the ECOG-ACRON study looking at abbreviated MRI versus TOMO. We have the DENSE trial, I think, which is it's a groundbreaking trial, which has shown that when you offer women MRI screening with women with extremely dense breasts, you find more cancers, you reduce interval cancer rates. So we have now evidence that there is a population who will benefit from screening. But screening has to be also cost effective and has to be offered to be able to be offered to a larger population. So this is where abbreviated MRI comes in there. And when we say abbreviated MRI for screening, the idea is we want to know, is the scan normal, abnormal? Do we need to do something else? It's if you have like a difficult a staging situation where you want to know, what is that, a satellite? Do I have to do other biopsies, extent of disease? Then I think the abbreviated MRI is not the way to go. I think we will have toolboxes. We will have toolboxes where abbreviated MRI will be in the screening toolbox, and a full protocol will be then in the other toolboxes, for instance, like pre-surgical staging, assessment post-chemotherapy for the residual disease. I certainly believe that abbreviated MRI is up and coming, and it is necessary to offer MRI to a wider set of women, to a larger population, because there is evidence mounting that we should also consider in certain populations that for screening. And this is where we will have a good option with abbreviated MRIs. And the second was kinetics versus color-coded maps. So the thing is, the color-coded maps, which are semi-quantitative, these are, I think, extremely helpful in clinical routine. Apart from the single ROI that you do for the curve assessment, actual pharmacokinetic analysis is a little bit more tricky, because most of the protocols are that we are required, like the fast protocols, have a temporal resolution of 60 to 90 seconds, which is not suitable for formal pharmacokinetic analysis. Even if you do faster protocols, you are usually on the verge, because going below 10 seconds is tricky. So formal pharmacokinetic analysis with Ktrans, KEP, you would have to do the ultra-fast protocols. So I think we should, for diagnostic purposes, I would settle in the middle with the semi-quantitative assessment using color-coded mapping. And you can also still, it's completely valid to draw your ROIs and get an idea. What I like about the color-coded maps, usually mainly the programs can already give you the functional tumor volume and give you more information, and the kinetics of the lesion as a whole. Formal pharmacokinetic analysis with Ktrans, KEP, etc., I think is currently in the research setting and does not aid that much in clinical routine, what you have from the semi-quantitative assessment.
Thank you for this extensive answer. We are out of time, but if you do agree, I still have 2 questions, and then we can call it a day for us. But if you don't mind, the question was, at the end of your presentation, you had a very very brief and I would like you to comment on IVIM. Can you comment further? How do you see it? What is your opinion about that?
I mean, IVIM adds very, very, very useful information. So the reason why I didn't expand on IVIM and other advanced diffusion weighted imaging models is because it is for clinical implementation. IVIM takes longer. We are talking about having a clinical routine imaging, and like I focused more on the patient comes for her screening or for her workup of a BI-RADS 0 lesion. If we go into the therapy monitoring, response assessment, response prediction probably even, then into the biomarker imaging realm, the IVIM and also other diffusion weighted models will have a mileage. They provide more information. It has been shown in several studies that you can increase your predictive and prognostic value on breast cancers. From a simple question, do I have to biopsy on this enhancing mass, yes or no? In a probably, and what I'm hoping is that this is not, that the multiparametric MRI is not restricted to academic centers, but everybody in private practice should be doing it. Then IVIM is sort of an overkill in the sense that you also don't have the time and have to make it cost effective. If you can, it will add information, but you also will have to have a dedicated evaluation of that. I think it's highly interesting, and to answer questions from therapy, response assessment, treatment, prediction, prognosis point of view, then we will be moving in this more advanced modeling realm anyway, sooner or later, be it with IVIM or other models.
Okay, yeah. Since we are talking about advanced application, and I think that would be the last question. Since we're moving into advanced applications, MRIs is not widely spread for the reasons that you have explained in your presentation. In your opinion, and could imaging be a breast option? If you know that CEST is currently developing and mostly in the brain, but do you think it could have its breast examinations?
It could. I mean, we are actively looking into that. So I intentionally left out all the other things that are potentially out there. We are actively looking to that. The problem is, like at the moment, with what we can do at 3 Tesla with CEST, is like we are often limited to one slice. Yeah, this is continuous work in progress. But when I look at what were improvements in hardware and software for DWI, where we started out when the first images, we were not even sure what kind of organ we were looking at in the image. Yeah, I think sure. there will be a lot of more work into that. And there not only CEST, there's also, I think, a very interesting aspect is hypoxia imaging. There have been publications looking into vascular architectural mapping, cuboid imaging for hypoxia assessment as a tumor marker. There's acidity imaging. There's a plethora of sequences in the pipeline, which currently are in the research realm. I do certainly hope that some of them make it out into the clinics. But the thing is, I think most important is that we have to have a package that works, is robust in clinical practice, adds information. What parameters from the current research realm make it into our toolboxes, we will see. CEST is a contender, hypoxia imaging is a contender. So there are several, acidity imaging. There's a lot of stuff that is out there. Some will also, I think, if at any given point we are moving to more widespread 7 Tesla imaging for breast, there can more be done with that. But I personally, haven't seen that happen in the last several years, last decade. So let's see what comes up. But there are options, and I think this is a rapidly forward-moving field, the functional imaging in breast, and this has shown to be a success story and improve ourselves. So I think we're not stopping here.
Cannot agree with you more. That's absolutely that is absolutely obvious what you're saying. So on this, I would like to conclude. First, I would like to thank you very much, Professor Pinker. It was really a great pleasure for us being with you today. This has been a terrific presentation, and I know that there are still a lot of questions that will be for remaining time. So I would like to conclude by thanking everyone here. We appreciate you being here, and hopefully see you next time. Again, thank you very much. and have a nice day, everyone.
Thank you for hosting. Thank you. Bye.
Thank you. Bye.